Hello, everyone, and welcome to Talk with a Doc, a new thought leadership series brought to you by HealthSnap, where we hear from the nation's leading healthcare experts on their perspective of technology's role in patient care post-COVID-19. My name is Samson Magid, and I'm the co-founder and CEO of HealthSnap. And joining me today, I have the fortunate pleasure of Dr. Jonathan Fialkow joining us. Dr. Fialkow, thank you for your time today. We greatly appreciate you joining us.
It's my pleasure, Samson.
So, Dr. Fialkow, I thought we'd start off with just a quick introduction to yourself and your organization.
Sure. So I'm actually a cardiologist by training. I still have a small cardiology practice specializing in lipid disorders and complex cardiac preventive conditions. But I have two roles within our health system, which seem kind of schizophrenic, but actually, if you dive into them, they're kind of very much related. So I'm our Chief Population Health Officer. We're in a very large fee-for-service health system and building around population care, the value-based proposition. I'm leading a lot of the vision and the strategies and the implementation of those types of programs. And I'm also the head of cardiology and our cardiology service line through our Cardiac and Vascular Institute. And we're building around the programmatic approach and identifying and providing resources in treatment, education, and so forth around chronic disease states and significant medical conditions.
Awesome. That's fantastic and very impressive. We've seen this year that the adoption of virtual care and technology in general has played a very different role in patient care post-COVID-19. How has Baptist Health South's strategy and innovation changed because of COVID-19, and how are you guys thinking about it in the future?
It's a very timely topic, and I appreciate the question. The reality is a large system with lots of different stakeholders and lots of different people competing for resources. One things we recognized, I and others, is that we need to organize ourselves around whether it be telemedicine or telehealth or digital health, whatever terms you use, so as not to create redundancies and inefficiencies and cross-purposed decisions. We started this conversation actually early in the year, and when COVID hit, it just accelerated the movement as a system towards this organized approach. So we now have a telehealth task force. I'm co-chair with our vice president who's in charge of our imaging services. And across our system and across the counties, we created several pillars and subgroups and various means of approaching this, like I said, from systematic approach. Now, what COVID did in particular is recognizing very rapidly, had we as a system, as has happened nationally, we had to change our care, whether it be in the medical practices, where we had to be concerned about patients getting exposed in offices or afraid to come into offices, but we still had to care for them, whether it be in our urgent cares and our emergency rooms, creating different means of patient identification and obviously keeping those that might be at risk as separate and quarantined from others. We need to use technology to both apply FTE resources to make sure that we're tracking where people can be best spent for where the needs are of the populations. So a lot of the things we're building towards the system and organizing were just accelerated with the COVID experience based on the significant urgent need for identification and treatment and disposition of sick patients. We went through that peak in July in South Florida. Hopefully we're not doomed for another one. Without a lot of these telemedicine and technology related solutions, we really would have been much further down a pathway of not performing. So we're all very thankful for that acceleration component. We'll say, every a negative, or what do we say? Don't let a good crisis go to waste. We did use this crisis, and it truly is and remains a crisis, towards getting that alignment within our system leaders towards this technology-related approach.
Yeah, that's great stuff, and yeah, let's hope there's not another spike coming in the near future here. But yeah, we hear I've been hearing the phrase a lot, once the genie's out of the bottle of virtual care, that it's kind of here to stay. Do you guys feel like that's the case in your organization's perspective?
We do. As one of the leaders, both in terms of the medical group and the clinical space and the value-based proposition, I'm very careful to let our non-clinical leaders know two things. Neither one are thoughts that I originally came up with, but certainly resonate. One is, the proper use of virtual care is using it for the right patient in the right place. It's not a substitute for a patient coming into an office or a substitute for a patient coming into an urgent care and ER. Arguably, it's to improve access for people who otherwise couldn't get care. There will always be patients who should wind up being physically seen as opposed to that virtual space. The second deliverer is, of course, what's the best PPE? It's a virtual visit. So, we're talking about, preventing the exposures through the healthcare environment of COVID and COVID related phenomenon. Well, if you can provide that care and the person is not exposed to others and that the others aren't exposed to that person, that's the best, PPE, and personal protective equipment. And those things tend to resonate with the non-clinicians. They think that, well, why do we need offices? We can just do everything virtually. No. And certainly in cardiology with our heart failure patients or patients with, increasing shortness of breath, we still need to see people in the office, and there's services that won't be efficiently provided. But if you're able to find those low acuity type visits and apply virtual care for those patients, we're able to improve access, decrease deteriorations, and of course, ostensibly decrease ER visits, hospitalizations, and ultimately costs in improving the patient care. So yeah, the genie out of the bottle, how well you can do it, what are the HIPAA related issues and the regulatory relaxations that came into place to allow us to incorporate this quickly. What will the payment models be in terms of patient responsibilities and reimbursements? There's still a lot we don't know, but I think that establishing that there's a cadre of patients who benefit from this and a lot of clinical care that can be provided this way, that genie's out of the bottle and it's going to be here to stay. What's that sweet spot to be determined? Very probably regional and kind of practice specific, but it's here to stay, no question about it.
Got it. That's great. And that segues really nicely into the next topic of discussion, where maybe you could provide for the listeners one example of one innovation or technology that Baptist Health South has adopted that's really transformed patient care. And then also more importantly, for any founders out there that are maybe looking at technology and digital health innovation, one example where something that you guys adopted failed or didn't go to plan, and more importantly, why did that happen?
Okay. Yeah, I mean, I can give you a couple examples on both. I think the biggest one would be, again, how quickly we transition into performing these virtual visits for patients in the practices. But I won't use that as my examples because it's kind of boring and kind of been done, though as critical as it was. But I'll tell you something who, in my role, I'm kind of a change agent within our health system, but something that was an accelerant. So I relatively early on, and I'm part of the leadership team with our health system, recognizing what was going on with COVID, even before we got hit really hard in South Florida, but also, from New York, as you can probably hear from my rapid speech and my accent, communicating with a lot of my colleagues up there. And of course, in March and April, New York was particularly hard hit, and hearing a lot of their experience, it started opening my eyes towards, wait a minute, rather than wait for that to happen to us, let's start preparing. So I started looking at various tools to help us remotely monitor patients for vital signs, temperature, O2 sat, respiratory rates, that might give us the ability to decompress our hospital and our ERs if and when we start getting hit with the surge. And I reviewed a couple of companies, and there was some out there. Of course, everyone redefined themselves as a COVID solution, in this day and age. And I found a company that I thought had a nice hybrid between the tool they used and the support they gave versus the price point. And I started messaging this to our health system leaders, and this was now May, and they were, what are you talking about? And we got plenty of capacity, and what do we need this? But use that messaging to kind of build the infrastructure support. So then, in fact, in late June and early July, when we were bursting at the seams, being able to provide this technology had multiple benefits. So basically, and you probably have seen some of these, it's a little sensor that goes on the finger for up to 8 to 14 days, and it monitors the O2 sat and the temperature and the respiratory rate. But what it really provided was the confidence to the emergency room doctor and maybe the admitting doctor to send someone home rather than admit, who was in that, I don't know what direction this person's going in, creating that monitoring ability such that if any of these vital signs fell out from the parameters we sent, we were alerted, we can contact the patients, bring them back in for that potential decompensation. And we wound up very quickly using it in hundreds of patients, to the point where now each one of the hospitals in the health system wants it and has that access. We're centrally monitoring it. And again, I use it as an example of success where a technological solution with a little bit of a monitoring aggregate algorithm accelerated processes in our health system that probably would have taken months by the time you went through all the vetting processes and privacy and compliance and all the multitude of parameters to get something new done. We did go through those processes, but in a very accelerated fashion. So I think that's an example where the COVID and then the technology started putting us in an accelerated process for new things like that. I'll give you an example where things didn't go so well. And I can get to specific technology things, but in our health system, they're looking for this holy grail, if you will, of a single app, for example, that any patient, i.e. consumer, can access and get anything they want with the health system. And arguably, that's a holy grail because it kind of doesn't exist. It's just, we know as the different components of what a patient may need from the healthcare system, from a practice, from their provider, what someone may need, whether it's scheduling an appointment for imaging and stuff. There are too many factors in place, and there's no uniform questions to be answered. So they started going through that path. What they did was they put in place, starting with a single software for the visits that were being done, the virtual visits in the clinical practices. I won't mention the company unless you want me to, but probably not for the purposes, but it wasn't built for it. It was built for kind of an urgent care type of delivery model. And, we had tons of technical problems and the patients were getting upset and frustrated and the doctors were. And it was an example where the decision was made using technology that the users weren't engaged. It wasn't built for that. And within 2 weeks, all the medical groups kicked it out and said, stay out of our space. And we started using different technologies. So again, looking for that single solution for something technologically based that's relatively new may not exist. So we have to figure out what are our priorities, what compromises will we make towards that single solution to get what we need, how can we work with industry to build towards what we need. It's great to have a company that says, work with us and we will help develop further what we're here for you. But that was a big failing and fiasco that led to a lot of patient and provider dissatisfaction, having a tool imposed upon us that was not built for what we're trying to accomplish. Hopefully those are the kinds of examples you're looking for. I'll tell you also, Samson, but that experience also led to us towards this, again, system-wide approach, multiple stakeholders being brought in for conversation towards these types of solutions. So we don't have one person with one agenda making decisions that can negatively impact many others who would otherwise be using that solution.
Yeah, no, absolutely. And that's great insight and invaluable, I think, for people to truly understand how, as an organization, you guys are now thinking of vertical integration. How do you actually centralize these decisions across the enterprise and not say, hey, does this work and can we apply it elsewhere, but actually think holistically about a digital solution. So that's great insight.
Takes a little longer, as you've seen with our personal experiences.
Yep.
But arguably, if we can mitigate as many negative consequences at the forefront, whatever we roll out, and when you roll something out, you'll have much greater success. What is it? You only have one chance to make a first impression. So if you're going to go to anyone with, we got a solution for you, we're going to make your lives easier or your patients' lives easier, and you screw that up, it's really going to be hard to get some traction with that in the future with those people going forward.
Yeah, absolutely. I think as an entrepreneur and working in this space, I think transparency is key. We far too often try to say we are something that we're not. And so I think the lessons learned there, it sounds like, is transparency, being very honest and open about who you are, and more importantly, who you're not, and the solution that you can provide to the organization. So that's great insight from you firsthand. Mm-hmm. As somebody that manages, population health, and you mentioned value-based care, that word is getting tossed around a tremendous amount.
Yeah,
and
buzzword.
I think it's a big buzzword. It's been in the industry for a long time, and I think a lot of people are starting to now use virtual care and telemedicine and remote patient monitoring as a means to create widespread adoption of quote unquote value-based care. But everyone has a different definition of what that means. So what does value-based care mean to you? And then how has the organization implemented any value-based arrangements, if at all?
So again, the 800-pound gorilla, but I think, arguably the simplest definition of value-based care would be speaking towards that triple aim, or arguably the quadruple aim, which is decreasing cost, improving clinical outcomes, improving or enhancing patient satisfaction, and the fourth one would be the provider satisfaction. And that's not what we do a lot in the fee-for-service world. It's very transactional. You do this and pay me for this, and I'll do this, and we don't think of the consequences. We started with a clinically integrated network a few years ago. We've now expanded it across a couple of counties. We started with a couple of shared savings arrangements with some commercial payers. We do have a couple of risk arrangements with some Medicare Advantage payers. We're now in Medicare shared savings. So we're really in this space. As a portion of our system's revenue, I always have these discussions with our system leaders. They'll say, well, we're only getting a small part of our revenue through value-based agreements. And I keep pointing out, but a lot of our patients that we're getting paid fee for service, they're in value-based agreements, whether it's through MSOs or ACOs or other Medicare Advantage payer models, that our transaction. Maybe you do this and we get paid, but someone's paying attention to how those populations are managed. Where's the best value for their care? And if we're not conscious of it and we're not able to provide that, those patients will eventually be moved elsewhere. So that's the kind of longer answer. The shorter answer is we built our value-based proposition, and we have well over 100,000 lives now that we have some form of value-based arrangement where we will get financial remuneration if we're able to decrease costs and improve quality. I kind of look at it like we started strategically with what I call the blocking and tackling. So that would be coding and documentation parameters, of which, there are some technology components towards that regarding the data mining and whatnot, for the providers, but also care gaps and transitions of care from the hospitals and those types of things. And we've done that well. Well, now we're entering what I really consider the more exciting part and the bigger part, which is chronic disease management. So now we have these populations, and we recognize, that a small percent of the population represent the largest amounts of our costs, whether it's 5% of the population represent 50% of the cost. These numbers are thrown around. And what differentiates those patients? Well, they have a lot of medical problems or chronic diseases, and they're not being managed. They're in a doctor's office for 20 minutes every 3 months. How much of their care is determined by that visit? Not a lot. So how do we identify those patients? How do we apply cost-efficient tools and resources to keep them healthier, keep them out of the hospital, and then ostensibly in the value-based proposition, share in some of the revenue that we're saving for the payer or for whomever that sponsor is, in keeping the costs down. And that's where technology is really important, whether it's using registries to identify the patients, whether it's remote patient monitoring for those complex care management patients, again, so we can keep them out of the hospital, keep them from decompensating, improve their quality of life, the patient engagement tools that are necessary to get the people to use these types of resources. And that's where we're at right now. So we're really concentrating on building out our chronic disease management system-wide department. Again, rather than each practice or each doctor having their own little tool or their own little, pet project, organizing it around a systematic approach, and caring for those patients, and then again proving that with quality and financial outcomes that we're making a difference. The next component, just to let you know, as a heads up from that value-based proposition, which we have to address arguably, is site of service. It's how we can figure out, who are those high-performing doctors and whatever the parameters are, where the facilities, where the costs are cheaper. That's a real heavy lift when you start going through these processes, especially as our system, since we're a health system that's not for profit, but we have a lot of independently, privately owned physicians in our system. So how do we align incentives and whatnot? But again, long-winded answer, going back to the original premise, it's how we can keep people healthier, keep the costs down, and everyone benefits from that. The hospitals, the providers, the payers, obviously the patients. That's where we're at right now.
Yeah, and that brings it to a great point of, as somebody that's looking at not just today, but how you guys are structuring in the future, and you think about your transition from that fee-for-service to more value-based payer arrangements and proving that out, more importantly.
Sure.
What's a solution or a technology that you feel right now is something that you guys are looking for, needed, but just haven't encountered yet in the market?
So I think going back to the original point, though, one recommendation, not that I'll give it unsolicited, is try not to boil the ocean. There's so many opportunities out there, and there's so many things that can be done as health systems from in that fee-for-service world or from that fee-for-service world. It's pick your priorities and create your milestones towards moving on to the next stage. That way also you get credibility and buy-in from people where you're not trying to change their workflows in life, where they haven't bought into any other benefit. As far as the technology component, again, I could tell you, Samson, is someone who gets solicitations from vendors. There's a little bit of a feeding frenzy out there. No insult intended, in terms of,
None
people
taken at all.
People, like you, great ideas, entrepreneurial, great solutions, and they're real. But how do you connect that to someone who's just, drowning in a plethora of needs and make your solution at the top of that priority list? How do we connect that? And I think that's where the difficulties are. Single source of truth, validated data helps, whether it's a single enterprise electronic medical record system or population health type medical record system, modules with registries helps. So that's technology, but really more on the reporting standpoint. I think when you're looking for tools, to me, I'm really excited about the chronic disease management, and as a subset, that remote patient monitoring component. If we can now provide means of monitoring patients' physiological data, mental state, and physical conditions from home remotely, but not have individuals lay eyes on every piece of parameter, but aggregate that data using whether it's AI or other systems to alert who's going to decompensate or who needs a little bit higher set. Look, we all have limited resources to apply towards our patients. If we can best apply those limited resources where we get the biggest bang for the buck, I think that's where it's most important. So while others in our system are really looking for those virtual care visit tools and how patients can navigate to make appointments for imaging and doctor's appointments, which are important, to me, the remote patient monitoring solutions and really trajectory are the most exciting. And I say that as both a cardiac and vascular specialist, especially concentrating on cardiometabolic disorders and prevention, but also in the population health space, because those are the most costly patients who will have negative patient experiences, costs, multiple hospitalizations, and other consequences down the road.
Yeah, no, couldn't agree with you more there, and that brings me to closing thoughts. I mean, you touched on it a little bit here, but creating a central approach to technology adoption system-wide, I think, is a common theme. It sounds like, and really thinking about how to offset FTEs and managing the patients that need the care the most, and most importantly, when and where. What are your closing thoughts? I mean, as we think about technology, not only today, but again in the future, post-COVID, and how that's going to change things potentially forever. What are your thoughts on technology's role in healthcare and healthcare delivery as you think to the future?
So again, automated processes from efficiencies and better quality outcomes are critical. There's huge amounts, again, a physician leader, practice leader, big medical group, tons of things that actually, maybe I can go back and do we have enough time? I'll give you a quick anecdote. And again,
100%. Yeah.
Right. So about 3 or 4 years ago, I ran and built our cardiology practice. We were acquired by our health system 2.5 years ago. We were still in the private practice model. I came into my office one morning early to pick something up, and I saw one of my employees sitting in front of about 3 piles, each one about 1.5 feet high of papers. And I'm like, what are you doing? And I'll cut ahead a little bit, but basically we received in the group about 3,000 faxes per 24 hours, which were all brought in digitally through the computer. And they were printing them and sorting them and giving them to the respective departments, who then scanned them in and then put them in another pile to shred them. So the data was coming in electronic and ending up electronic, and in between, we had copying and printer expenses and FTEs and shredding. And I said, there's got to be a better way. And we started looking, and we found, actually, quite frankly, a very robust company that has software technology to automate those processes. And it just incredibly improved our patient experience and the workforce experience and our productivity and stuff. I use an example as, first you have to know what is deficient in your space. You know what I mean? If you don't know what your space is, or you don't know what needs there are for your patients or your workflows or your scheduling, your doctor scheduling, then you won't be open to saying, what are the resources out there? So start knowing your space, knowing what just says, wow, man, wouldn't it be great if this were automated? Can it be automated? Then you start seeking out, and again, large, intermediate, and small, and startups versus robust companies. There probably are solutions there, because you're not the only ones that have those needs. You're not the only ones that have those experiences. And when you start connecting your need with a capable vendor that has a solution, the technology really can enhance, again, that quadruple aim. The physician experience is better when they have less clicks, and they have, their eyes are brought to things they need to see and not dealing with a lot of stuff they don't need to see. When they know their patients are identified and cared for when it's outside of their direct vision. The patients are great when they're not only to be monitored and watched from home, and it doesn't involve a doctor visit, or they can access their medical care or the health system needs through apps and things like that. When your health system can aggregate all this information centrally, and that's what we're working on now towards a logistics center. Why have 5 different ICUs doing all this when we can centralize all these data and we can have one team of people? Why have different telemetry teams monitoring rhythms at every hospital? That's all done centrally, and it's just a phone call to connect the people. When you can start consolidating using the technology, both in terms of the hardware and the software, and then find those solutions for problems you have, I think that's when you're most successful. The alternative is when people try to give you solutions for problems you don't have. Wow, isn't it great if you had this? And wow, I want that. But that's not really a problem right now. We got bigger fish to fry, so I want to put my resources where I need them. When you connect, I got a problem, and there's someone out there that's got a solution, that's the perfect world and the most gratifying.
100%. That's awesome insight, Dr. Fialkow. Really appreciate it. That brings us to the end of our Talk with a Doc episode. Dr. Fialkow, can't express it enough. Thank you so much for your time today. Greatly appreciate it.
My pleasure, Samson. Always a pleasure talking to you.